We will have a live case and a few very interesting lectures. The session will be co-moderated with Dr. Anderson from Cheltenham, who is in the UK, and Professor Lobaton, who is already in the live endoscopy room and will guide us through this case. So I suppose that we move to the endoscopy room to see a first case by Dr. David Tate, who will tell us how to approach patients with a suspected upper GI bleeding.
We can really see it nicely here. Just as we sit on angulus there, you can really see it beautifully, the snake skin of portal hypertension. And then as we come up to the fundus, we see the main event, but I'm just going to focus on Xavier's question for a second. So we'll take a little bit of air out of here. I'm going to come back through here. And of course, we are indeed, a very good point, interested in looking for the presence or absence of esophageal varices. And of course other lesions, but we've checked there are no other lesions that we're aware of. And so Xavier, what do you think about the appearance here of the distal esophagus?
Yes, well, we can see at 1 o'clock there is a beautiful varix who is present there, but are not so many.
There are not so many, and it's flattening out almost completely when I'm inflating. Would you agree?
Exactly. Yes, I agree.
So I think that we can say that because this patient, as you nicely heard from Hannes, is repeatedly bleeding, that's probably not the cause of the repeated bleeding. It's also important to note that we have certainly looked for other causes of bleeding in this patient. She's had a complete colonoscopy with nothing found, and indeed some abdominal imaging which has not shown a source.
There's also, I can't see it very well from here. Is there a kind of a red dot on the varix?
Yes, indeed. And so actually that's a good point. We also did this procedure a few days ago when we weren't certain we were going to treat this because we were trying to work the patient up. There was no blood in the stomach at the time, and it was bigger then, and there was a red spot on it. But the patient has continued to have melena in the interim, and so we can only assume that this is the responsible lesion. And Xavier, what about the options here in terms of treatment, non-endoscopic treatments? So yes. She's already on portal hypertensive lowering therapy. She's had terlipressin, as far as I know. And the option or the role of TIPS here?
Yes, TIPS can be considered in these patients. What we have to take into account is, of course, availability of TIPS. It's not available in every hospital right away. Here in our hospital we have this option. We can have it rapidly if you want. Second point to take into account is the liver function, underlying liver function of the patient and potential contraindications for TIPS. I have understand that the liver function of this patient is a child C+ patient, so it's quite advanced liver disease in the context of alcoholic cirrhosis. Maybe there's a component of alcoholic hepatitis who is even decreasing liver function. So I think it would be perfectly appropriate to give a local treatment to this varix before a total workup of the patient is finished.
Okay, so we are really now wanting to show you the technique. So first I'm going to just talk with the scope in, but my colleagues and I are just going to talk, and if you can maybe take the zoom in on here over what we're doing. So Maureen is a great colleague of mine, great friend of mine, and here she has got the delivery system for the histoacryl glue. So we're just going to talk a little bit. You shout at me and I'm going to say, because you don't have a mic. Do we have the microphone for Maureen? So I'll just hold it up at you, Maureen. So tell us a little bit about how you made it.
Now, first we took a needle of 1 millimeters, the biggest one we have in our unit, and we flushed it with lipiodol.
Okay.
Now we enter the scope with this needle, not already with histoacryl.
Okay.
Histoacryl has to be prolonged with the lipiodol right before you enter the varix.
Okay.
If we do it now, before we go into our scope, it gets rock hard and we cannot flush it anymore.
And we break the scope, right?
And we break the scope.
Which is what we don't want to do, okay.
So this is pure lipiodol.
Okay.
We go in. Talita, my colleague, will, when we enter, she will make a new syringe with lipiodol and histoacryl. Okay. When she is ready, we have to be in, so we can inject it right away.
So we'll show that now. Huh?
Okay.
Okay. And the only other thing to say is that in the nursing part of this symposium, there's a beautiful movie about how to draw up histoacryl. So you can check that out if you're not sure, or maybe if one of the doctors is on his own at night having to treat a gastric varix, then maybe that's a useful resource for them too.
this is a procedure that could be done by every gastroenterologist, but not every gastroenterologist is able to do endoscopic ultrasound. Okay, thank you very much for this very interesting session.
Known, that's the second most frequent situation. Probably the majority of them are diverticular bleedings, but we know that diverticular bleeding often stop from themselves, and that's probably the reason why there are a lot of people that are admitted to the hospital, but that in fact at the end we are not sure that it really was a diverticular bleeding or not. In fact, all therapies that we use for endoscopic hemostasis have been used in diverticular bleeding, and all are being shown to be efficient, all in case series. There are no randomized controlled trials between all these different therapies. Important again, use a good bowel prep before you start this kind of endoscopy. Use at the moment of your endoscopy a water jet irrigation. I would always propose you to use a cap on the endoscope.